Thank you.
Well, thank you for that wonderful introduction, Mitra. You're so kind all the time. And looks like Elizabeth is in the mountains. Oh, wait, there's an ocean too behind her, or like.
Ireland. I'm representing right now. Well, I'm also a little bit of Irish, like from my dad's side. So just got to be wearing your green. I'd pinch you. I'd pinch you.
I have my green ring on. I almost finished till I had to show my ring, and I was like, "It's green. Leave me alone." Okay. I'm Shipra. I'm one of the Peds Infectious Disease faculty at WVU Medicine Children's. I'm also the project lead for our project Firstline and WVU NICE. So I want to touch base on that. Mitra, we can get started with our slides. I think I would follow what's on the slides more than otherwise I will just keep talking randomly. Okay. All right. So we can go to the next slide. I have no financial disclosures or conflict of interest with any material presented. Like I said, I am one of the Project Firstline leads, so there is going to be content from Project Firstline, which is a CDC material that's available for everyone. We can go to the next slide. This is the basic outline of what we're going to discuss today, a COVID-19 update on Project Firstline in West Virginia NICE. Then we'll cover 2 Project Firstline training materials pertaining to environmental cleaning, disinfection, and ventilation. And for the last 2 parts, I apologize if this is not going to seem, but I want to use this opportunity to see if there is more interest in using some of the material, or if you guys want to use some of the material for training of your staff, because it's not, these 2 topics were kind of the things that were not covered in med school. And I only learned about them because I work in as an infection control medical lead. And so that's why I know more about it, but something to keep in mind. All right, we can go to the next slide. So a brief COVID update. This is our COVID-19 weekly cases per 100,000 population. You can see our numbers were way high with the Omicron wave, and it was high across the board. But you can see the peak was led by 18 to 29, which is like that teal. Is that the color? The dotted teal? Everyone agrees? Okay, good. My colors are bad. Again, if you look, the children, our pediatric patients are represented in the different shades of yellow. So you can see, yes, there were high numbers, especially in the 12 to 15, but then not so much in the other younger age groups. We can go to the next slide. So you all must have heard about how CDC transitioned to the new monitoring, which is now called as COVID-19 community levels and indicators. So this is more applicable for what we should be doing in the healthcare setting. How do we know where we are in terms of COVID transmission in our community? This used to be called as this CDC community COVID-19 community transmission map, which is still available. If you look at that, we still don't look very pretty with this. But now this takes into account your inpatient admissions, how many of your new admissions are COVID-19, how many of inpatient beds are occupied. So kind of like giving us that healthcare model when we should implement more of public health care, public health interventions like masking and all the other things. So the first thing that we need to look at is new cases. If they're less than 200, then we can go to a low, medium, high. However, if we are 200 or more, which we are right now for the state of West Virginia in general, we then can only be classified as medium or high. And then based on your new COVID admissions or percent of staffed inpatient beds occupied. So it's interesting to see that they also have staffed inpatient beds in there, because we know whenever we have a surge, we also lose some of our staffing. So that's interesting to keep in mind. So we can go to the next slide. So this is our current map. West Virginia is shade of orange and yellow, which is high and medium. So more work to be done. It's surprising that Ohio is green, except for like a little bit of yellow in there somewhere. So low to medium, but you guys must have read about how the wastewater surveillance is pointing towards an increase or uptick in COVID-19 cases coming up. So if you look at that dashboard, there are more testing sites that have noted an uptick in COVID-19 cases in Ohio. So something to, especially with the rapid availability of antigen testing, many people are not going to have the PCR tested, but the wastewater surveillance is still going to give us that grand scheme of how much COVID-19 is around. We can go to the next slide. This is the pediatric report that AAP publishes every 2 weeks. There have been about, hold on, 12 million cases. Hold on, somebody's knocking on the door too. I apologize for that. Somebody really had a burning question. So about 12 million COVID-19 cases have been reported total in pediatrics. This is about 19% of all cases. Children 0 to 18 account about a quarter of the general population. So there's still a chunk of pediatric children who have not had COVID. Overall, there has been there had been a decrease, but recently over the past 2 weeks, there was a 1% increase, which was way higher than the Omicron surge. Cumulative hospitalizations and mortality has pretty much stayed stable at 1.4 to 4.6, and then mortality is around 0 to 0.26%. We can go to the next slide. This is what the overall numbers look like. Our peak was way higher with peaks across the board in during the Omicron surge, and now we're at 41,000. But you can see, like, even if you look at the alpha and the delta waves, the peaks were pretty much same, but here we are like 4 times the explosion, 4 times during the Omicron surge, which is reflective of the higher transmissibility of Omicron, as well as how we also had less mitigation strategies in place. We can go to the next slide. I think Dr. Moffat touched on this in the last one. So Omicron, the original variant is BA1. There is a sublineage BA2, BA3, and you guys are probably hearing about it. This has a higher effective reproduction number, about 1.4 times higher. It seems to be resistant to antisera and antivirals. There are studies ongoing if vaccines, our current vaccines are working. So that's why there is a lot of push on getting Omicron specific or like a variant specific vaccine out into public use, because all of us who've gotten our boosters, we're kind of a little out from that 4 to 6 month window. We can go to the next slide. So BA2 is that sublineage that I was talking about, and you can see it's about a quarter, and it's expected to be the dominant variant circulating across the board. You can see Omicron is right there in the dark purple, and that's the pink. We can go to the next slide. So why is this worrisome? Because in Europe, especially UK, where the UK, Denmark, they have seen a surge in their Omicron, their number of COVID cases, especially after the surge. Okay, where did the colors? Okay, so you can see the green peaks are the Europe, and then you can see they were coming down, and now we are starting to see a spike again. So that is being attributed to this new variant, and we'll see what more information we get. We're usually 2 or 3 weeks ahead of the European curve, and that's why we're paying a lot of attention to this data. And what was interesting was they Again, I think it is because we all have antigen tests so readily available that they did not see the overall COVID-19 cases going up initially, but then they saw that the hospitalizations were going up. So that kind of gives you a sense of there is more virus circulating in the background, and you don't know about it because people are either testing by antigen testing. Also, they lifted a lot of their indoor masking and a lot of the crowd limiting initiatives that we had in place. We can go to the next slide. All right, I'm going to pause here and see if there are any questions that I can help answer regarding to the content we did so far.
Dr. Gupta, nothing in the chat yet either.
Okay, all right. And we'll go through the Project Firstline update really quickly. All right, we can go to the next slide. So, Mitra, yeah, there you go. So what is Project Firstline? So it's a new national training collaborative for infection control to help prevent the spread of infectious diseases in the US healthcare settings. The basic aim is to provide foundational and practical knowledge directly to frontline healthcare personnel and the public health workforce. It was interesting, I was watching the documentary on Netflix on Paul Farmer, who's one of the MDs who started working in Haiti and did a lot. And you could see how much public health has been and how the community workforce has been, the community health workers were emphasized every time there is an outbreak. And I think that's what Project Firstline is also trying to do, is to try and disseminate this information so all of us are trained to be able to run with this information whenever and apply to any kind of outbreak. This was all done during COVID. It might seem a little outdated because if you look on the website, they're still talking about Delta variant, which was a little annoying, but here, that's why I'm here. We can talk about Omicron and all the fun things. The other thing Project Firstline really emphasizes is the why behind infection control actions. So if, especially touching into the adult learning model, if you understand the why, it's more helpful and you're more likely to incorporate that into your daily work life. We can go to the next slide. So the other piece that we are with this grant we're working on is creating a network for infection control and epidemiology for the state of West Virginia. We can go to the next slide. And some of you might have seen these slides. This is a collaborative effort. We're the second year into a grant, and I think we have made a lot of headway with getting the Project Firstline material out, helping disseminate more information. So it's a collaboration between Marshall University and WVU. It's funded through the West Virginia Department of Health and Human Resources. We can go to the next slide. Our vision is to enhance access to evidence-based infection prevention and control strategies for all West Virginians. Mission is to provide expert advice, education, and training in infectious diseases, infection control, and infection prevention to all facilities and organizations in West Virginia. And I'm hoping we are able to reach out to the places that are not affiliated with an academic center to be able to access resources, to be able to get a hold of us, to ask us questions through our consult center. We can go to the next slide. So that's our wonderful WVU team. And on the next slide, we have our Marshall University faculty team. You might have noticed the PEDS team is really heavy on the WVU team, but we're a happy balance. There is a lot of adults, internal medicine people trained on the Marshall side, so we compensated by getting a lot of PEDS people on the WVU team. We can go to the next slide. These are consultation regions. WVU covers green, purple, and yellow, which is also kind of the places that our WVU affiliated hospitals are. So I met with the infection preventionists, which are through the WVU health system, and we were able to disseminate some more information about us. Marshall covers the Western, Central, and Southern regions. So more of in their niche, closer, more visibility, and a very, like more closer to where they are. We can go to the next slide. We do have a consult center set up. Unfortunately, in the period of 1 year, we have not gotten any consults. I take it as being happy about how accessible we are over the phone, that we don't get any consults through this consult center. But that is one thing that we really want to emphasize, is the use of this consult center, so we can do more work, are able to respond to people who don't know about us. So we're gonna work with the state epidemiologists to disseminate more information. School nurses, we're gonna be sending out books and flyers to help everyone know about what this consult center is about. We can go to the next slide. All right, before we go to that, to the third and fourth point, any questions? Nothing? No? Okay. All right. So these two basic Project Firstline material will cover. There are some videos, and it's supposed to be interactive, but we'll see how this goes. All right. And if you guys don't like this, let me know. We'll not do this again. All right. We can go to the next slide. So this is on environmental cleaning and disinfection. And I felt so silly reviewing this material, because a lot of this is not covered during med school, like especially when we had a little outbreak in the NICU, and we were going into how did you clean this, and did we do UV light, and then we realized, like, and I did not understand the reason why we need to clean before we disinfect, especially if you're using UV light, because if you have crud sitting, your UV light will not go in. So that's why I thought we might cover this topic, and it could be a conversation starter today to how we can use this, or you can use these training videos for your healthcare staff, especially new employees who are starting off, just to cover the basic cleaning and disinfection. We can go to the next slide. So we'll cover what is the difference between cleaning and disinfection, why does it matter, what is contact time, and then we'll spend a few minutes reflecting on it if we learned anything new in this presentation. We can go to the next slide. So learning objectives are describe the difference between cleaning and disinfection, and then discuss why it's important to follow label instructions on a disinfectant product. We can go to the next slide. I think this is the poll. Mitra, you're in charge of the poll.
Yes, let me go ahead, stop screen share and launch the poll.
So you have to pick what is the definition for cleaning and disinfecting, and it's a single choice.
And can everyone see that okay? Awesome, thank you. There we got some folks participating, 39%, 50% participated.
Oh, maybe I'm also supposed to answer. That's why it's not working on my end. I was like, why is this only says 0 or 1 answered? Ay, ay, ay. Every day it's something new.
So it says 67 have participated, 71.
Oh my gosh, yes, let's get to 100%. So it's a good divide.
So close.
So close.
21 of 28 have participated, 23 out of 28. Okay, we're almost there, everyone. 4 more responses.
How do you see that? Where is that? Okay, it's probably at your end. Okay.
All right, I think I can go ahead and maybe end the poll.
Yeah.
Let's see if I can launch it. I'll go ahead and share the results. It should be anonymous, so. All right, can everyone see the
Oh
results?
my gosh, come on, you guys. Okay, you guys all got it right. So disinfecting is killing of germs, and cleaning is removing the dirt and the, oh my gosh, now I feel defeated in my, I'm gonna waste your time then. It's okay. We'll still talk about it. All right, we can go back to the slide. So all right, so you all got it right. It's the last option. Disinfecting is killing germs, cleaning is removing dirt and some germs. All right, we can go to the next slide. So cleaning is a process that removes things like dust, dirt, grime, and other spills, smears, and everyday messes from surfaces. I think of this, what I used to do pre-COVID in my house, just dusting and getting the so it looks pretty and shiny. But now we're in disinfection phase at my house where we're using Lysol wipes and just ready to bleach everything down. So disinfection is a process that kills germs. We can go to the next slide. So we'll touch on why cleaning and disinfection matter. We can go to the next slide. I think that's the video and we'll see if this works. Okay, everybody cross your fingers and toes. Is it gonna work? Mitra,
Can't hear it.
you.
Everyone can hear that or no?
Try it again, Mitra.
Okay.
And it's wonderful to have.
There you go.
In an earlier episode, we had talked about cleaning and disinfection and the difference between the two. In general, cleaning removes dirt and gunk and removes and sometimes kills some germs. But disinfection makes sure that as many germs as possible are destroyed or killed. Today we're going to talk just a little bit more about why cleaning and disinfection are so important in healthcare. Not just for stopping the spread of SARS-CoV-2, that virus that causes COVID-19, but for stopping the spread of lots of different germs and infections. It's common sense that cleaning is important to keep infections from spreading in healthcare settings. Cleaning and getting rid of dust and dirt and body fluids keeps germs away from people. Disinfection, when you think about it, is also common sense too. Killing germs definitely keeps them away from people and therefore keeps people from getting sick. Even though it's common sense now, it's important to think through all the reasons why we're so careful about keeping the environment clean. Now, you probably clean and disinfect when you're at home. You clean your windows, you wash your dog, you might even disinfect some parts of your kitchen or your bathroom. But cleaning and disinfection in healthcare is a bit different. Why is that? When we're at home and we're healthy, our bodies have a lot of built-in ways to protect us from infection, including things like our immune system or even our skin, which is a very important part of our immune system. But in healthcare, we have a lot of patients who are ill and weak. Germs are more likely to cause problems in these patients because their immune defenses might not be the same as somebody who's healthy, living at home. With some patients, you can see how they might be vulnerable to infection if they have burns or wounds, for example, or if they're having a procedure done where germs can get under the skin, like having an IV put in or a catheter. But a lot of patients have things going on that you can't really see. Like if their immune system is weak because of the medication in their cancer. So it's incredibly important to have the environment free of germs, especially in places where they can pose risks to patients and to us and to our coworkers. So, for example, when a patient leaves a room or is discharged, right before a new patient goes into that room, it should be clean and disinfected. Make sure that the next patient is protected from the previous patient's germs. We also clean and disinfect things that get touched a lot, like door handles, keyboards at the nurse's station, light switches. We call all of these high-touch surfaces, and they need more frequent cleaning and disinfection because of all the hands that get on them. Because we know that germs get on our hands, then they can get all over the place, and that can make we also clean and disinfect things that may not get touched or shared as often, but that we know tend to be dirty and have a lot of germs on them, so important. A lot of the germs that we're seeing in healthcare are unfortunately becoming more resistant to antibiotics. That means if somebody gets sick with those germs, the antibiotics, those medicines that we use to treat them, might be less likely to work and less likely to help that person get better. There have been outbreaks before where people have gotten sick from these germs in healthcare, and antibiotics.
Okay, I don't know what happened to the video, but we can move on to the, so that is the lead person who has been doing videos for Project Firstline. We can go to the next slide.
Would you like me to play this video?
No,
as
we
well?
can go to the next slide.
Okay.
We will cover the rest of the material. So we talked about like there are some patients that you know are going to be susceptible to infections, and I think there's a lot of stress on preventing nosocomial acquired infections, especially like CLABSIs, COTIs. But how does that translate into the outpatient setting, which I gather most of us also work in the outpatient setting, and this group primarily is in the outpatient setting. So I take the example of cystic fibrosis. There are clear guidelines, especially for places that are CF centers. We want to make sure that all of our rooms are cleaned. You let them dry, you use the specific wipes, and that's why it also impacts your clinic turnover. Your rooms are occupied for a longer time because you're waiting for those to clean. So they have weakened immune systems. They're more susceptible to bacteria that would normally, like Pseudomonas and the different bacteria that would normally not bother us as much if you're immunocompetent. So primarily in healthcare, we have patients who are ill or weak. They have weak immune systems, or they could have devices, or they could have poor skin integrity. And that's why they are more susceptible to infection. All right, click. This has animations, Mitra. But so germs are more likely to cause problems in these patients because their immune systems are not the same. Their neutrophils are not so powerful that they can just do oxidative bursting and fun things and phagocytize it and get rid of it. So that's why. And we can go to the next slide now. So besides letting the healthcare environment should be kept clean. That is very common sense. If it looks sparkly clean, does it mean that it is really clean? Like, do you have germs? You cannot say that. So it is important to keep the health care environment clean to stop germs from spreading, because if you have not performed the first step of cleaning, you will have that dust or grime sitting and your disinfecting process is not going to work. We can go to the next animation. So like Dr. Carlson touched on, where and when. So patient rooms, high touch surfaces, surfaces and objects that often have a lot of germs on them, like toilet seats. So we, during our infection control meetings, we review ATP counts on different high touch surfaces. So environmental services goes in, cleans the room, and at the end of it, they will sometimes randomly go around and check on these high touch surfaces to see what the ATP, and there are goals set by infection control as to where your numbers should be. So that's another way of measuring it. And we often see if it is going to be the high touch surface, and that's also a guide for what should we focus on next time. And if it's not EVS that's cleaning that surface, who else is responsible for cleaning it? So like there's some surfaces that the nurses clean. So that helps us guide our process too. We can go to the next slide. So covering a little bit about contact time, we can go to the next slide, Mitra. So contact time is also called as dwell time. This is the amount of time a disinfectant needs to sit on a surface without being wiped away or disturbed to effectively kill germs. I think of this as, just waiting for the chemicals to help neutralize or kill the bacteria or the viruses. And if you don't let that time pass, you are not achieving your purpose. We can go to the next slide. So the disinfectant label is pretty important. I think of this as reading instructions to putting something together from IKEA. Like if you don't put the instruction, if you don't read those instructions, then you're going to be lost forever and be lost. So what information do you need from a disinfectants label? So I just wanted to cover this piece because if you have new staff that is coming into your healthcare facility, to just basic cover, they might think if they already know this stuff that we're being silly by making them review all of this information. But I mean, I did not know about this. So the first thing is the product EPA approved? So Environmental Protection Agency, they are the ones that set together, that have these lists together of disinfectants that work for various bacteria, viruses, what it doesn't work against, on which surfaces can the disinfectant be used. And working with the infection preventions, I've learned so much more about like each, the NICU isolate comes with, you can clean this piece with this special disinfectant and you can do this with it. So it's very specific. And that's why this is the lesson I learned during NICU, during my NICU rotation too, was that you need to have a NICU dedicated staff for EVS services. Otherwise you will not be able, because it's so specific to everything. What germs has a disinfectant been proven to kill? We can go to the next animation. Does the product need to be diluted? Like, would it work if you mix a bunch of water, or is this too concentrated? We can go to the next one. And then what is the contact time? To think about how long you have to let the surface sit. So that applies to also inpatient rooms after they're discharged, to clean the room. When can the next patient come in? We can go to the next thing. So do's and don'ts for infections. Do follow the listed contact time. This ensures items are disinfected to keep germs from spreading. Don't rush the process. And I have heard a lot from the EVS staff, like, we're on a crunch, we need to turn around rooms, especially OR suites, but they all know the importance of waiting for the disinfectants to work so that we're not, we don't have bacteria and germs hanging around when the new patient comes in. Don't wipe the surfaces to dry it faster. Don't blow on the surface to dry it faster. Or, you know, sometimes you can let the air, you can increase the, like we do at home, we sometimes run the fan if the floor has been mopped, but sometimes that doesn't allow the disinfectants process to work because it needs to like dry up on its own to allow for that contact time. So don't blow on the surface to dry it faster. Also, you will be kind of putting your own bacteria and viruses onto it. So it'll be silly. We can go to the next slide. EPA has a list N, as in Nancy, is a searchable database that covers the SARS-CoV-2. So like I mentioned earlier, these Project Firstline materials were made in with the intention of disseminating, helping information being spread around for management and mitigation strategies for COVID. So that's why the slide is still there. We can go to the next slide. So reflection, we can go to the summary slide after this. So key takeaways are: cleaning removes visible dirt, dust, spills, smears, and grime, including organic material like blood, as well as some germs from surfaces. It is important to clean before disinfecting because dirt and grime can make disinfectants not work as well. Disinfecting kills germs. I think you all knew point 1 and 2. It is important to keep the healthcare environment clean to stop the spread of germs. Follow the instructions on the disinfectant label, especially instructions for contact time. So that is really crucial. That is the big message that I got when I read this. It's not you just clean your cap or helmet and walk away, and or you can just clean it and put it on and go from there. You have to wait for the disinfectant to work. We can go to the next slide. All right, before we move on to ventilation. Anything, questions? No? Okay, let's go to ventilation and hope the video works in this one. We can go to the next slide. So we'll cover how does ventilation work, why does it matter, and then again, the key takeaways. We can go to the next slide. So learning objectives are why good ventilation is important. And it's not just in healthcare that this is important. Somebody just posted something about how this is more being emphasized for in general across the board for all public buildings, for schools, and that is going to be one of the things, priorities to get this rolling, especially during the winter time when we're all going to be cooped in to figure out how to keep good ventilation going. Discuss one way that ventilation works to reduce the amount of germs in the air, and describe one reason why it's important not to take steps to improve ventilation yourself without working, like opening windows, and without working with the staff in your facility in charge of air handling and ventilation. We can go to the next slide. So how does ventilation play a role in our lives? I can give the silliest example, especially when my kids are in the car, or when they were little, they used to poop. We would have to roll down the windows because it was disgusting. That's how we increase ventilation. The other good example would be if somebody cooks something in the kitchen, you turn the vent on so you can get rid of the smell. So those are like the house, the home, in the home setting, even in your office kitchen. That's something. The other ventilation or venting out would be 2 years of COVID, still cannot deal with it. So this is a good vent space too, to talk about how annoying COVID has been. All right, we can go to the next slide. So ventilation is the movement of air in and out of an enclosed space. For example, the circulation of fresh air to a room or a building. We can go to the next slide. So how does ventilation work? Which the next slide is going to involve a video, and we'll see if that works. All right, Mitra, make it work.
All right, I'll work my magic. Fingers crossed.
Proper ventilation is an important tool to use when trying to stop the spread of germs in healthcare. Every time we breathe, we release respiratory droplets into the air. These droplets can be harmless, or they can carry infectious germs like viruses. But respiratory droplets are just one of many particles in the air around us. Other air particles can come from things we do routinely, like cleaning procedures, walking on a carpet, and even moving our clothes. Other things that we use routinely in healthcare, like some mechanical devices, including toilets and heater-cooler devices in operating rooms, can also release particles into the air. Good ventilation systems will remove things from the air we shouldn't breathe in by pulling old air out of the room and mixing clean air in, which together with other infection control actions helps prevent the spread of germs. For more information, visit cdc.gov/Project Firstline.
You can go to the next slide. So why does ventilation matter? And this is another video. Mitra, make it work. Magic time, please.
Welcome back, everyone, to Inside Infection Control, our video series here at CDC's Project Firstline. I'm Abby Crump, an infectious diseases doctor at the CDC, and it's wonderful to have you here today with us. We talked in an earlier episode about what ventilation is, the movement of air in and out of spaces. But now, let's talk about why it matters and what you can do about it. Let's talk first about air in healthcare. Having clean air in healthcare can help reduce the risk of germs, particularly that of COVID-19, from spreading among patients and among your coworkers. You may not know this unless you're part of your maintenance staff or you work on air systems in the building. But nearly every room in a healthcare facility has a recommended number of air exchanges. An air exchange is the time that it takes for a room's old air to be completely replaced or nearly completely replaced with new air. We usually measure it by the hour. So we think about how many times per hour the air in the room It's complicated, and it's a lot more than most of us need to be experts on it. Even I have the basic principles, and then I talk to the experts about a lot of the complex stuff. But it's important to know how often the air in that room is being exchanged or cleared. And that will tell you how long the room should sit after a person leaves and before another person can come in without a respirator or other PPE. It's really important to note that we're talking about entering without PPE. You can enter the room with your PPE before the air is exchanged, and of course, while the patient is still in there. But without PPE, the wait time is important, and that's something that we recommend to wait for before you go in. You can always talk to your building engineering or maintenance staff to find out more, or people who deal with your heating and cooling systems. Even before COVID-19, these recommendations were in place for air exchanges because it's that important to make sure that air is reasonably clean and moves in and out of rooms. One good way to check if there's ventilation of any sort happening is to look for vents and fans, just like you would in a house, where see where heating and cooling is coming from. There are some simple things that you could also do to increase ventilation. So, for example, if somebody's microwaving fish in the break room, what do you do? Well, you open a window, you turn on a fan, or you avoid the area until the stuff has gone away. The air has been exchanged. But in healthcare, things like opening a window or changing the fan in the room can change the balance of air across a lot of different spaces. So one room is affected by another, is affected by another. And that's why it's important to work with the people at your facility who are in charge of air handling and ventilation, and not to do things on your own, so that you don't affect air movement in the long run. So, ventilation is important in healthcare, and it's one of many strategies for keeping germs from spreading. And you should use it as much as you can to keep that air clean. Thanks again, as always, for joining us. Please be sure to follow up on Facebook, on Twitter, on YouTube, and check us out on the website at cdc.gov/Project Firstline. We will see everyone back here with the next episode.
All right, we can go to the next slide. So, any questions about all that was discussed in this video? Doesn't look like, okay. So we saw that during early time of COVID, when we started putting in HEPA filters, especially to create spaces that had more increased circulation, where we could at least put our patients under investigation, or little NICU babies who were born to moms that were COVID positive, because there is one airborne isolation room in our NICU. But if you had a bunch of babies, especially during our surge, so how did we achieve that? We called our facilities manager engineers, and we asked them how we could increase the circulation, and they recommended. So we made one pod as our COVID isolation pod, and that it was really annoying because those vents were, especially during winter time, you could feel extra air coming in and it was colder, but that was just increasing the circulation. So steps to support good ventilation: know how long it takes for the air in certain rooms, especially patient rooms, to clear. And these are really clearly set out in the infection control document from CDC, which rooms, like the airborne isolation rooms, how much circulation they need to have, how many air exchanges they need to have. Usually for outpatient clinics, it's higher for procedure rooms, for ED and stuff like that. If you're entering a room without recommended PPE, make sure the air in the room is cleared first. So especially if a patient has been there with an illness, with a pathogen, that you need to make sure that many air exchanges have happened. And that is important if you're not going to wear PPE. Don't take actions on your own to change how air is handled. Have questions, ask the person with who is responsible for air filtration and ventilation at your facility. We can go to the next slide. So reflection. I think this is something that is very pertinent to the inpatient setting, but also thinking about it in the outpatient setting. Just making sure that your clinic is has all these things in place, making sure all the vent spaces, all the vent openings are not covered, which sometimes is hard. At least in my home, it's hard because we put heavy furniture around the vents. And so to think about all of those things, we can go to the next slide. So this is a handout that has, do you have remaining questions about ventilation? Otherwise, there is good information on the CDC's website about how to increase ventilation. Most of the times, and you can see right now, there are a lot of HEPA filters that are available online that you can buy to place in your homes. But if it's a healthcare facility, it's recommended that you follow up with your facilities manager to review all of this information. We can go to the next slide. So there's a feedback form that I'm hoping you guys could fill out so I know what I need to do better, or if you don't want to hear about these sessions again, I would be happy to not cover any of this information. Also, I would encourage you all to go to the Project Firstline, and if there is something specific that you want to cover, and we can work towards, there are new modules that are going to come up, but there are certain ones that are very pertinent to the pharmacy stuff and stuff like that. Like this was this was EBS plus facilities, but then it's important. I mean, I don't remember learning of anything about any of this stuff during med school. So it's important to just look this over, and we can work towards this, especially before winter hits. If there are ventilation problems in the building, we can fix those so that we are not seeing a lot more COVID and flu and all the fun viruses that circulate during winter when we're all cooped in. We can go to the next slide, this is also, so you can there is a facilitator toolkit that I reviewed with the infection preventionist at the health system level to, which kind of covers how you should be able to run a session on your own. I would be happy to review any of the contents, any of the videos like we did today with any of your healthcare staff if you have, and some of this, so today I used like a 20-minute and a 20-minute session, but there are 10-minute and 10-minute sessions too. So like if you have a shorter agenda, or if you want to emphasize something, I would be happy to do that with you guys. And then there is a toolkit guide that I can review if that's going to be helpful. Okay, we can go to the next slide. All right, this was my St. Patrick's Day joke. All right, happy to take any questions.
Thank you so much, Dr. Gupta. I loved how interactive your presentation was, and so much great information in there. As usual, I'll be sending out your slides in the recap email, but if you have any additional resources or the form you mentioned, you want to email that to me, I can include that in the recap as well. So we did get a question in the chat. I can go ahead and ask that. We have about 10 minutes, so we can utilize this last few minutes for Q&A and discussion. The question asked, do you recommend we just check the CDC for information on filtration systems, or are there specific filters you recommend? It seems as with masks, there may be some out there that are less reputable than others.
So I would go through the CDC's website because there are a lot of filters out there right now. And I would, if this is for a healthcare facility, if it's for your clinic, I would really talk to the facilities manager, because they are, I mean, after working with Charlene for almost 3 years now, I've learned so much more of things like the airflow needs to be in this direction, and things that only the people who are working in this day in, day out understand. I don't have any specific preferences. I am ashamed to say, but I've not bought a an air purifier or a ventilation system for my home. But there are so many out there that you can get. It's funny thinking back when I was back home in India. My mom would wake up in the morning and open all the windows, but it was also warm there. But we cannot do that here during the winter time. And when so they were visiting me last month, and they were so inching to like opening all the windows again. I'm like, oh my gosh, that's a way to improve ventilation, but also not to give us a frostbite. So I mean, it's definitely going back to our roots and improving the ventilation in areas. But I would follow the CDC guidance and do follow the recommendations up there.
Thank you so much, Dr. Gupta. We got another question asking, does COVID virus travel through heating and AC systems or just open air?
So it has been documented that early on there were studies, I forget, was it from Hong Kong or China, where it would travel through the HVAC system. But if there was a connection, like if the outlet from the room was also an inlet, or like it was connected, you're usually supposed to have an offset point and not have those connections in between rooms. So the pressure direction, the airflow should be in one direction and one set. So there were a lot of like basic science studies too that reported this. But then also you have to keep in mind that this virus is very susceptible to drying. So as soon as it's out in the air, it does dry up. And once the moisture is gone, it just dries and it's not helpful. However, if you are using this in a basic science modeling, so going back to the initial Hong Kong, China outbreak, they noticed that people were getting infected in different apartment buildings, but they had trouble with their duct system, like it was connected. The basic science models, you will see most of the studies are PCR based. So even if the virus is dead, you would still pick them up on the PCR. So there are limitations to both sides, but that was like a real life example. So they were isolating people who had tested positive in the same building, and they noticed that people were testing positive that had not previously tested positive. So it does travel through the air vent systems. So often, if people are going to stay in a hotel, I usually just let them know that make sure you have the vents on. For most of the newer establishments have better air ventilation systems as compared to the older systems. Okay, that was all I had.
Thank you so much. No, that was super helpful and informative. Anyone else with any thoughts, questions, comments, and feel free to unmute as well. We'd love to hear from you. But I'm also happy to read out chats. All right, well, if there are any questions after the fact that anyone thinks of after this session is over, you can always email us and I'll make sure to send it to Dr. Gupta to have addressed for you all. But if there's nothing else, Dr. Gupta, did you have any other final comments about Project Firstline you wanted to mention? Or, I mean, you covered everything, but I wanted to give you an opportunity.
I just wanted to mention about the long COVID. I think Dr. Moffat had talked about, so we specifically don't have a special long COVID clinic yet. What Dr. Moffat's study is it's a part of a grant of a major study where we will be evaluating or like surveying children with who have symptoms consistent with long COVID. But we would be happy to see any child who you think post-COVID is having some deconditioning, or you have any concerns. So we have been getting a lot of referrals. So our infectious disease group will be happy to see them, evaluate them, and then redirect wherever they need to. I just wanted to touch. I didn't know if Mitra, your question was answered last time. You had emailed and then I completely forgot about that.
No, that's perfect. Thank you so much.
Okay, that's all I got.
Awesome. Thank you so much, Dr. Gupta. Again, we really appreciate your time and sharing your expertise on all of this. And We thank you all for joining today's session as always. I do want to shout out everyone. Please let us know any topics you want to hear for the upcoming sessions in the springtime and everything, just because we want to be addressing topics that you all want to hear. So just email us topic ideas and we'll make sure to put those in the books. The only announcement that I have is that our next session will be on April 21st from 12:15 to 1:15. And we hope to see you all there again next time. Thanks, everyone. Take care.